So I think I should have started by saying, turn off your camera or at least mute yourselves. This will be recorded until we reach the Q&A portion, and then we will stop recording and unmute people who'd like to ask questions. So anyway, that's a little bit about me. My father and brother died very young of heart attacks that we learned later were due to undiagnosed FH. Two of my children were diagnosed with FH, and one of my grandchildren has it. And Lulu is going to introduce herself now.
Hi, everyone. My name is Lulu Thrower, and I recently became an ambassador for Family Heart Foundation. I am an individual living with homozygous familial hypercholesterolemia. It's a more rare and aggressive form of FH. I had my diagnosis later in life as a mom of two young kids. And quickly my health declined and I ended up needing an emergency open heart surgery. I'm really happy to be here and share my story and hopefully empower other people to be curious about these conditions and get testing early. It was kind of what we'll be talking about today is I heard a lot cholesterol runs in our high cholesterol runs in my family, but I was the first one to really have early onset heart disease. And also the silver lining of my story is that I could get my kids tested as well. Happy to have Anne here today with us and be a part of Family Heart Foundation.
Great. So here's our medical advice disclaimer. I'm just going to read this quickly. Information in this webinar is for your information. The content is not intended to be a substitute for professional medical advice, diagnosis, or treatment, and it does not constitute medical or other professional advice. Medical information changes constantly, so the information in this webinar could be updated or change. And if you're a patient, please follow up with your doctor and your medical team for specific recommendations pertaining to the treatment of you or treatment of your family. And we have Family Heart Foundation is actually an amazing source of resources about familial hypercholesterolemia. You'll see here familyheart.org/resources is where you can go to see these sorts of pieces of information and many, many more. There's a QR code on the slide, and that's a way to get there. But I think familyheart.org/resources is probably the easiest way to remember it. We have a care navigation center, and I think maybe our expert today, Ann Dodge, will talk a little bit more about that. We will put a link to visiting Care Navigation in the chat at some point, but again, just going to familyheart.org/care is a way to get connected. And we also will probably be talking to you many times over the next meetings about Cholesterol Connect. In most states, you can get a free Cholesterol Connect kit, and you'll get free screening for your LDL cholesterol, lipoprotein little a, which is another topic. It's another lipid disorder that's not part of your lipid panel that also can cause early cardiovascular disease. And with that testing, you get access to Care Navigation. And you can find out more about that at cholesterolconnect.org. So here's our meeting today. We're really excited to talk about, oh, I'm sorry, this is our meeting for next time. This will take place on October 8th. And our next topic will be about the importance of screening cholesterol in children, which, we'll have no trouble filling an hour talking about that and all of the guidelines that if you have children, your pediatrician likely hasn't mentioned, but we want you to know this information. So that's October 8th. You can register at familyheart.org and power-fh-meeting. And we'd just like to acknowledge and thank the sponsors of the Empower FH calls. Okay, so let's see if I've missed anything. I don't think so. Here's how the hour is going to go. Ann Dodge, who I'll introduce in a minute, is going to be giving us some really fabulous information about the kind of high cholesterol that runs in the family. Um, I think everyone has been muted now, which is great. When the recording is over, we'll stop the recording and we'll have a Q&A. So even as you're listening to Anne, if you'd like to put your questions in the chat, then we will be able to read them and have Anne and answer them and hopefully have a good discussion about any questions you might have. And so Anne Dodge is a Family Heart Senior Care Navigator. She's one of our care navigators. She's an advanced practice nurse prescriber. She's a nurse practitioner, and she's been with the Family Heart Foundation for more than 2 years. Um, and so I'm pleased to introduce Anne, who's going to give us a lot of good information today. Anne?
Thank you. Thank you so much, Casey. And thank you to our amazing volunteers that help put this all together. And to all of you for taking time to join us. I'm really honored to speak with all of you today. So we'll get started, and please let those questions flow into the chat because we'll have plenty of time to talk at the end. So today we're going to talk about what is heterozygous FH, and I'll just call that FH, and I'll explain the difference between heterozygous and homozygous. How common is it? How is it inherited? Why is this diagnosis often missed and treatment delayed? Why is it important to diagnose FH, and how can family members be screened, and where can families get help? Next slide. So what is it, FH? So there's two components. So keep in mind there is clinical criteria for diagnosis. The two clinical criteria are a family history of early heart disease and high cholesterol. By high cholesterol, we mean LDL. In children, the LDL would generally be over 160. In adults, normally over 190. However, it can be lower, but that's the diagnostic criteria. It can also be diagnosed through genetics, but that is not required to have a formal clinical diagnosis. Next slide, please. So there's two forms of FH with a broad spectrum of severity. So that would be Lulu's homozygous FH and Casey is heterozygous FH. So Casey got one gene of FH from one of her parents that caused her FH. And Lulu got one gene from each parent that causes FH. So she inherited two genes. The huge difference with that is because there's two genes, it's a lot more severe presentation, where LDL will be over 400 since probably age 2. Heart disease begins in childhood. Lulu, I think you had your bypass in your 20s or 30s, very young. And so oftentimes children in their teens would have bypass with homozygous FH. There's many new medications out to treat homozygous FH. It's extremely rare, affecting only 1 in 300,000 people. Heterozygous FH, which we're going to mainly be addressing today, is much more common, affecting 1 in 250 people. The one gene comes from the one parent. The LDL is over 160 in childhood, which you can figure out by age 2. All you have to do is check the lipids, and over 190 in adulthood. First heart attack or stroke or cardiac event occurs between ages of 30 and 60. And usually, because this is such an undiagnosed disease, usually the first symptom of this disease is for young people having a heart attack. There's can be people in their 20s, early 20s that die from this disease who are untreated. Most respond to drug therapy. It's the complications of heart disease are extremely preventable if treatment is started at a very young age. And this affects 1 in 250 people. Next slide, please. So effects of very high LDL without treatment. The picture on the left is a normal artery. with FH, the LDL and inflammation from the LDL create what's called plaque. And the fancy word for this is atherosclerosis. That's what heart disease is, but we can call it plaque. There's plaque buildup that in FH likely does start in childhood. You just can't see it, you can't feel it until you have that heart attack. If you start treatment in childhood, the plaque is extremely soft and pliable, and the statins, which are approved at age 8, I'll go into that, can regress and almost completely regress the soft plaque in children where they grow up with clean arteries, and their risk of an early heart attack comes down to someone that never had this disease in the first place. If it's not treated, we'll get to the third picture, severe atherosclerosis. This would be between the ages of 30 and 60, when pieces of that plaque break off or block the arteries and cause a heart attack or stroke. So FH can cause ischemic strokes, the picture on the right, aortic valve stenosis, which is calcified hardened plaque around the valve in the heart. The aortic valve has 3 cusps that open and close. Aortic stenosis is when those valves have plaque growing on them and they start sticking together and they don't open and close properly, and you can develop heart failure from that. The other probably most common symptom from this is a heart attack. And then atherosclerotic disease can also develop in the legs, the picture below, and that is called PAD, or peripheral artery disease, where plaque develops in the arteries of the leg. And you'll see a lot of people, older people, who get a lot of pain in their legs with activity, super red flag for atherosclerosis in the legs or PAD. The symptom of the pain in the legs with PAD is called claudication. Next slide, please. So physical findings in FH, like I said, the first symptom is a heart attack with a heterozygous FH, just the one gene. There is hardly ever any physical signs present in young people. And if there are, they're often misunderstood. Older people with pretty high LDLs and people with homozygous FH. Because their LDL is so high, they develop cholesterol deposits under the skin that poke out and cause these bumps in the skin, common to find in the elbows, the hands, the Achilles tendons behind the knees, often seen in clinics, and many doctors will send them to a dermatologist to have them removed and never think to check their lipids, and they're completely missing this diagnosis. The pictures on the right with the eyes, with the little bumps on the inside of the eyes, those are cholesterol deposits pushing out from the body out into the eyes from too much LDL from FH. So those are called xanthelasmas. And then below that is the white circle around the iris is a fatty cholesterol deposit around this iris. That is not normal. People without FH do not have that. So those are signs that when I taught in the nursing school at UW-Madison, I would stress to my nurse practitioner students, you have to find these symptoms. You have to understand what they are. They might be rare, but if you find them, that would be life-saving. Next slide, please. How is FH inherited? So FH is an autosomal dominant genetic disorder. And by dominant, I mean that a parent has a 50-50 chance of passing that gene onto each of their offspring. So each child they have has a 1 out of 2 chance of inheriting FH from that parent. So if they had 4 kids, they could have 4 kids with FH. If they could have 2, they could have none. So each child has the 1 out of 2 chance of inheriting that gene. Next slide, please. How well do healthcare providers do in diagnosing FH? Unfortunately, they don't do well. So there was a survey of 500 US cardiologists to assess their understanding of FH. 60% did not know that it was inherited dominant fashion. 80% were unaware of the prevalence, how common it is. 70% did not recognize FH when given a case study. And none of them realize that individuals with FH are 20 times more likely to have a premature heart attack if it has been untreated. Next slide, please. So universal pediatric lipid screening is the key to attacking this disease, identifying it, treating it early, preventing heart disease. But universal pediatric lipid screenings have been in place since 2011, where all children aged 9 to 11, and again at age 17 to 21, should have a lipid screen. And then children with a family history of FH or early family history of heart disease should have their cholesterol checked at age 2. The primary rationale for this universal screening is to identify children with genetic FH. But most pediatricians, family practice doctors, they're screening children due to obesity, not due to family history. And around the country, unfortunately, only 2 to 22% of children are screened between the ages of 9 and 11, and almost none at age 2. And a key initiative of the Family Heart Foundation this year and next year is to improve screening rates nationally in children. And this is, again, we've had great help from our ambassadors who are going to be helping us lead some of these efforts as well. Next slide, please. So the importance of cascade screening means that when the first person who's found, Lulu mentioned she was the first person found in her family. So at that point, cascade screening would mean her children get checked, her siblings get checked, her parents get checked, her grandparents get checked, the children of her siblings get checked. It's because the younger the patient is when FH is diagnosed, the more effective the treatment. Statin treatment started in childhood can prevent the onset of early heart disease. So we start first with we call it the proband. So Lulu was the proband, meaning the first patient in the family to be diagnosed. And then we spread it out, like I just mentioned. Knowledge is power, and Family Heart Foundation offers many resources to help with families with cascade screening, including Care Navigation and many of our infographics and webinars. Next slide, please. Why is it important to diagnose FH? Next slide. Because it's life-threatening. 1 in 10 heart attacks under the age of 50 are caused by untreated FH. Next slide. Untreated FH leads to extremely elevated LDL exposure from birth into adulthood. So this chart shows the average age of onset of heart disease in untreated individuals, with the blue line with homozygous FH. The average age of heart disease starts at 12.5 years. With heterozygous FH, the red line, the average age of heart disease starts at 35 years. The green line is people that don't have FH. The average age of heart disease starts at 55. But if you look at the arrow on the right, those ages will decrease. It'll happen even earlier if they have these other risk factors, including female sex, smoking, hypertension, diabetes, increased triglycerides, low HDL. HDL is the happy or healthy cholesterol, so you want that high because it's protective. But if it's low, it's a risk factor. And then lipoprotein A, which we won't go into a lot on this talk, but I'm sure you'll hear more about that later. LPA or lipoprotein A is another significant risk enhancer for heart disease that everyone should be checked. And it affects 1 out of 5 people. Next slide, please. So people ask, can diet and exercise cure my FH? The answer is no. Statins are needed. Most people need multiple medications to control their LDL, at least 2, sometimes 3. But diet and exercise are still very important because diet and exercise contribute to about 10% of your LDL. So if you can have a very good control of your diet and exercise, you might be able to lower your dose of medication. So good control of diet in FH means very controlled saturated fat intake. That doesn't mean your life has to be miserable. For the kids in my clinic, I had a pediatric lipid clinic for years. I would explain to them, I would have them make a list of saturated fat foods. I just say, what do you eat from a cow? What do you eat from a pig? And what do you eat that's fried? So then they would make their little lists, and I didn't even have to explain saturated fats because that covers it right there. And coconut oil, that's worse than butter for raising LDL, has a ton of saturated fat. Coconut oil can be used anywhere but in the mouth. So also it helps to have a high fiber diet, at least 10 to 20 grams per day, grabs onto the LDL so you can excrete it. In our clinic, we referred all FH patients to a dietitian and coach them on an exercise routine. Next slide, please. So I mentioned before, I can't underestimate this because the other risk factors all play into FH. You do need to tightly control your LDL, and we have a great slide on our webpage to help people determine LDL goals. And that you'll determine as well with your clinician. But the other risk factors are hypertension, diabetes. People don't realize that diabetes is actually, it is an endocrine disease, but diabetes is actually a cardiovascular disease. It affects, the side effects are to the circulation. That's why people untreated diabetics lose their feet. They lose circulation in their extremities. It contributes to plaque buildup and inflammation along with the LDL from FH. Metabolic syndrome, if you don't know what that is, it's usually related to overweight and obesity, a lot of hormone imbalance, a lot of insulin resistance. That's a huge risk factor as well. And the new GLP-1 inhibitors are becoming an excellent treatment for a lot of these issues. People that get on the GLP-1s, and hopefully insurance will catch up pretty soon. And by the way, they're improved in children down to age 12. GLP-1s with appropriate weight loss can take care of hypertension, diabetes, metabolic syndrome, overweight and obesity, and sometimes even inactivity, because these people that are overweight have trouble exercising. It doesn't help with smoking, but luckily, you know, that's not as common as it used to be. But I was the smoking cessation person in our hospital as well. And so our care navigation services can also help with smoking cessation if needed. And again, everyone should know their LPA. It affects 1 out of 5 people, and it is genetic. Next slide, please. Like I mentioned, stress, this is probably the most important point, is treatment should be started very early for FH. That's why diagnosis early is so important. Most people I talk to in care navigation are in their 30s, 40s, and 50s before they're diagnosed. In my clinic, we would diagnose children at age 9 because it was a pediatric clinic. And therefore, their parents would come in and they were only in their maybe 30s, early 40s, maybe even late 20s. And they had no idea they had it. So we had the child diagnosed, we could screen the parents, get them in for treatment at a young age, and help them prevent early heart disease as well. So the earlier the treatment, the greater the risk reduction for heart disease. Next slide, please. So where can families get help? Next slide. Family Heart Foundation resources. Next slide, which Casey reviewed some of those. Our Care Navigation Center, we have 3 Care Navigators at the Family Heart Foundation, and I think the other 2 are on the call, Miranda and Aurora. We have a broad range of experience between the 3 of us. I'm a nurse practitioner. Aurora's specialty is public health, Miranda's social work. And so we cover a lot of bases. People can schedule a free, there's no charge for our services, a free Zoom call. We have 45-minute free Zoom calls, and we will cover help with, you know, asking questions. We usually give you a list of things to ask your doctor about because we're not allowed to provide direct medical advice, but we can help you with questions based on guidelines and based on, you can share your labs, you can share your medications, we can discuss treatment goals based on guidelines, we can educate you about the different medications and the side effects, the ages medications are supposed to be started. So it's a very valuable service. And there's actually a lot of emotional support that goes in with these calls as well. Next slide, please. We have many webinars on our website, familyheart.org. Just type in webinars in the top left. You have every topic, FH, homozygous FH, lipoprotein A, cholesterol basics, just numerous excellent webinars. Next slide, please. These are some of the tools that Casey shared, and many of these are great to help with cascade screening, where the proband, like Lulu, wouldn't have to go be the bad guy and tell everyone what they have to do and educate everyone about FH. She could just print out all these resources and email them to her family, share them at Thanksgiving. And then she's not the bad guy. So we can be the bad guy. We want to be the bad guy. We want to be educating people. Next slide, please. So these are new diagnoses with calls that we get at the Care Navigation Center. The most common diagnoses we get questions about is elevated lipoprotein A, and that does make sense because it affects 1 out of 5 people, and it is on our Cholesterol Connect program. It is a test that's included along with the lipids. So people are finding out unexpectedly that they have a high lipo-A, and they're shocked and scared and want our Care Navigation services for that. And then the second most common is increased cholesterol, which many of these people I talk to just say, but high cholesterol runs in my family, and they have no idea they have FH. So if they meet clinical criteria, I'll say, ask your doctor about if you meet clinical criteria for FH, and then they can hopefully get the formal diagnosis and get the treatment that they need. And then the third one, kind of just, they don't really put in a reason. They probably have a million questions. And then the fourth one is people, 15% with who know they have heterozygous FH, and they're maybe just found out, maybe just lost a family member, maybe just had a child diagnosed. But a lot of these calls for the 3 of us, I think, are kind of talking people off a cliff. There's so much emotion and fear and unknown things about this issue and this diagnosis. So next slide, please. Oh, and then I should mention the lowest number, of course, was the homozygous FH on that slide, just 1%, because it only affects 1 out of 300,000 people. So inquiries by topic, the most common question we get, and usually most people have more than one issue they want to talk about. Excuse me. Finding a specialist, understanding treatment goals and options is a huge one. Information for newly diagnosed, learning about clinical trials, family screening services, helping with cascade screening, navigating health insurance, especially with getting approved for some of the PCSK9 inhibitors that, I don't know if you've heard of them. This talk isn't specifically about medications, but that's been an incredible medication for people with FH who have trouble getting to LDL goal on the statin ezetimibe. Navigating health insurance, connecting with others, so we can share our Facebook support groups. And then many people are concerned that their treatment isn't working and wonder what they should be doing next. Next slide, please. Our foundation works very hard on keeping this specialist map up to date. It's on our website. You can just type specialist map into the top left search engine, and then also in Care Navigation, we can help you find a specialist. We have 600 specialists on our map from around the world, providers from various specialties, and people think, oh, I think I have to go to a lipidologist. No, that's not true. Lipidologists come in many flavors: cardiologists, endocrinologists, internal medicine, family practice, nurse practitioners, physician's assistants. So we can all carry that extra title of lipidologist. but they can fall under very many specialists. Some people think they have to go to a cardiologist to talk about all of this, but sometimes cardiologists are still getting up to date on FH and LPA. So it's probably more helpful to use our map so that you can go to someone who knows about FH and lipoprotein A. So this is a great resource to assist patients in finding care. We continually are vetting the specialists, reviewing them, and continuously updating the map. Next slide, please. So I mentioned the emotional mental health issues related to heterozygous and probably a lot more so homozygous FH. A new diagnosis of FH can lead to experiencing extreme anxiety about the future, fear of the unknown, anxiety about other children, fear of dying, which I hear all the time, fear of dropping dead, actually, grief, guilt, depression, anger, and isolation. And all these feelings are normal and valid. The diagnosis is shocking to patients and families, and there can be anger and guilt that it was caught late. But we let them know they're not alone going through this, and there's definite ways we can suggest to help you through with these feelings. Next slide, please. So I think number one, and why I think our care navigation services are so impactful, is, yeah, you can go to the next slide, please. Thank you. Is that knowledge is power. So we can help you find a specialist. We can educate you about the new diagnosis, treatment options, and guidelines. We recommend counseling with a trusted family member, a professional counselor, or a care navigator. Like I've mentioned, we have social work on staff as a nurse practitioner. I have a lot of experience in counseling. We're not professional psychiatric psychologists, counselors, but we still can offer you support. And then we have our Facebook community groups. The Family Heart Foundation has the FH groups and the lipoprotein A groups. And there's a lot of parent support within the FH group too, and with those Facebook groups. And those groups are monitored very well by our care navigators and our ambassadors to look for misinformation and make sure we have the correct information out there. So there is reason for hope and optimism with early diagnosis and effective treatments. Next slide, please. So the key messages are, if left untreated, FH is a life-threatening genetic condition that causes premature heart disease and stroke. Children with a family history of FH or early heart disease or stroke should be screened at age 2, and all children should undergo a screening lipid panel between ages 9 and 11. Everybody, no matter if they're athletic, skinny, healthy, obese, anybody, all kids, because even without FH, 40% of children in my clinic that were screened had abnormal lipid panels, even without FH. And that would be from our American diet and lack of exercise. So those kids usually show up with a really high triglycerides and a low HDL, but they need to be, attended to as well. So all children need to be checked. FH can be diagnosed and managed, but up to 70% of people born with FH are not diagnosed, leaving them at very high risk. Early diagnosis and treatment lowers cardiac event risk. At present, there are many effective and safe medications available to treat FH, and most people, the majority of people with the correct treatment, dramatically improve their LDL and dramatically lower their risk of early heart disease with the medications we currently have available. Next slide, please. And happy to take any questions.
I was just going to hop in to say that, to remind people that if they were waiting for the end of Anne's really information-packed presentation to think of questions and put them in the chat, please do that now. And Lulu's going to help us by reading the questions.
I don't see any in there just yet, but I do have a question. Anne, that often comes up. Um, are statins safe? And what if I have side effects like muscle pain? If someone goes on a statin, they have because they've been diagnosed with FH or high LDL, um, and they start to have side effects, then should they just give up, or what should they do next?
Mhm. So first of all, side effects are very rare. People think they're common because of everything they read on the internet. There was a study of 15,000 people on a statin, 15,000 on placebo, and the placebo group had more side effects than the statin group. A placebo is a sugar pill. So in my 11 years of having children on statins with FH, we had probably 250 kids with FH in our clinic. In 11 years, I had one child that had muscle aches. So then we checked the CK, which is the muscle enzyme, and asked them if they just, ran the 50-yard dash or did all that stuff in school. And they'll be like, yeah, I did. And if the CK is only mildly elevated, it's activity that causes their muscle pain. But when anyone on a statin gets muscle pain, we all get muscle pain, right? Even if we're not on a statin, we all do. So, but if you're on a statin or just starting one, everyone who gets muscle pain on a statin will say it's from the statin. So then we check the CK. If it's a muscle related side effect, CK is creatine kinase. It's a muscle protein enzyme. If the CK is more than 3 times elevated normal, then it would likely be due to the statin. So the first thing we would do is check a CK. If it's just a mild elevation, it's because they ran a half marathon. If it's 3 times normal, we take them off that statin, wait till it goes to normal, and then we switch to another statin. Statin side effects, there's 4 or 5, there's probably 3 main statins most of us use all the time. There's about 5 statins. But if you have a side effect to one statin, they're usually not transferable to another statin. So we never give up on a patient with FH that needs a statin. We switch to a different statin and then low and slow. So I would, if someone did have a side effect, or this is probably more common in adults because you hear of side effects more often in adults, which is interesting because kids don't read the internet about statin side effects. So what we do is switch it. What I did was I switched into another statin, always start at the lowest dose, wait 2 months, recheck the lipids. If you're not at goal, raise the dose. But for patients that were ultra sensitive, and I'm not saying I wouldn't believe them, I totally give them the benefit of the doubt. If they are convinced that their side effect is due to the statin, I'll stop it, switch to another statin, but I'll start it at not only the lowest dose, but half of the lowest dose every other day. Because then they're like on a whiff of a statin and likely will not feel anything. And then tell them after a week or 2, if you're not feeling anything, go up to the full minimum dose. And usually they just glide right into it. So it's just how you manage it and how you educate your patients ahead of time, because most people do not have side effects to statins.
Thanks, Anne. It looks like there's a couple of questions. I think Lulu was going to take those.
Yeah, so we have a question. Can health insurance coverage be impacted by a positive genetic test?
By a positive FH test or a positive genetic test?
The question asks specifically for a genetic test, but both.
Okay. So genetic testing does get a little complicated, because if you apply for health and life insurance, and they can use genetic tests, but FH diagnosed FH, it's fully covered, it's covered by your insurance, your health insurance will not cover your FH. It's thanks to the Family Heart Foundation, it has its own ICD-9 code. Thanks to universal lipid screening that is now in Bright Futures for the American Academy of Pediatrics. Those are the guidelines that all pediatricians are supposed to follow for preventive care for children. Anything that was able to get into the Bright Futures preventative guidelines are required to be covered as preventative medicine for all insurance. So, and statins, the insurance isn't really an issue anymore. Most of them are generic. So most of them are like, even if you don't have insurance, $5 to $10 a month. I don't know. I can't answer that question completely about the genetic component. But probably most people with FH don't even have genetic testing. You can, but you don't need it. If you do have it, there's 4 different genes that cause FH. However, there's a bunch of genes we have not yet discovered that cause FH. So if you have a known clinical diagnosis of FH and you go get a genetic test and you're an adult, it might only be positive 50 to 60% of the time. So you do have FH, but you're 40% of the people will have a negative genetic test. So I don't like to lead my patients down the pathway of you need to get a genetic test to confirm that you have this. It's not needed. You can diagnose it strictly with the clinical criteria of early family history and LDL level.
Great. Thank you, Anne. So if I'm understanding correctly, the takeaway from that is that you don't need a genetic test to be diagnosed with FH. You can be diagnosed straight from your LDL score, and your results will not affect your ability to get healthcare insurance.
Exactly.
Great. Okay, we have another question, which is, does FH hop between generations? I have FH. My 2 children do not have it. My oldest grandchildren, 13 and 11, do not have it. Does my 4-year-old grandson need to be tested now, or can he wait until he is 9?
Okay, so say that line again. The person has it, but the children don't.
So I think this is a situation where like a grandparent has FH and their children do not, and their oldest grandchildren also do not have it, but they have a new
Oh,
grandchild. And does that
yeah.
grandchild
Okay, great. Yeah, I just saw it in the chat. That makes sense. So, she has FH, the grandma. Her 2 children did not get it from her. So, so her children, yes, it's good they were screened, because what if the dad had it? So that all children still need to be screened. They would, if they had it, they wouldn't have gotten it from the mom. They would have gotten it from the dad. So does a 4-year-old grandson need to be tested now, or can he wait until he's 9? The answer to that is, what is dad's LDL? What if dad's LDL is 250? And the oldest 2 kids didn't get it from the dad, but the 3rd one could have, right? So for sure they all need to be screened at age 9, but that young one only needs to be tested if there's suspicion of FH or early heart disease in the dad. Does that make sense? Or is it too complicated?
I think that makes sense. As somebody who is, falls under the category of like the, rare, one might say, worst case scenario. I think it is always best, and this is obviously a personal opinion, but to err on the side of caution. If it's not, if you're able to have your child screened, I would say the earlier the better. And you either find out that they don't have it, like the rest of your grandchildren, or there could be that really rare possibility that they do, and I would want to know. Um, so, um, okay, we have another question. Um, okay. How does LPA link into FH?
Okay, that's a great question. So I like to explain that they're both very significant risk factors for atherosclerosis and developing early heart disease and strokes, okay? But I explain it as LPA and FH are two naughty boys in kindergarten together, and they're in the same classroom and they get into all kinds of trouble together. So what we want to do is separate them out from each other. So we get rid of the LDL, basically getting it down as low as we can, treating the FH. Then the LPA doesn't have as much to get in trouble with. They're better behaved. So the LPA, yes, leads to inflammation, atherosclerosis. So does the LDL. We don't have medications currently approved to lower just the lipo-A. But what we can do is if we lower the LDL even more in the people that have FH, lower it even further, then lipo-A isn't going to be as much of an issue. Does that make sense? It will still be an issue, but just it'll be less of a risk.
Yeah, I think that makes sense. Thank you, Anne. Um, Anyone else have any questions? Let's see. Oh, what age do kids start treatment if they have homozygous FH? And maybe we can talk about heterozygous FH as well.
Okay, sure. Children that have homozygous FH are started on treatment the minute they're diagnosed. It's considered a medical emergency. Children with heterozygous FH, statins are approved in children starting at age 8. Because of the universal screening we instituted in Dane County, here where I live in Wisconsin, it was 5% when I started the clinic, and by the time I retired, we were close to 60% screening rate. And so we had a lot of 2-year-olds that were getting screened because we would let parents, and we partnered with the Adult Preventative Cardiology Clinic at University of Wisconsin. So we had them, we were referring kids and parents back and forth between each other. So we are identifying more very young children with FH 2 and up. So we would get them into our clinic early. Every 1 or 2 years, we'd see them just to recheck their LDL, go over dietary stuff, like you shouldn't be on whole milk, all that kind of, no coconut oil, all that. But then some of those parents, they really understood the disease by then, because every appointment we would do more education about the disease and the treatment and what to expect when they turned 8, etc. And some of them came in and just said, please, can I start it at age 7? They were like desperate to get started. And I'd be fine, no problem. That's just off label. I have no problem with that. So, but it's age 8 in children.
Thank you, Anne. The silver lining in my experience after having my diagnosis of HoFH was that I could get my kids screened. We found out when my son was 4 that he also had HoFH. And then we also found out that my daughter, who was 7 at the time, is heterozygous FH. So my son was able to start treatment very early, which is great, so he can avoid what happened to me, and we can be proactive and make those decisions and choices. So I always am erring on the side, even if, and the genetics are a little tricky too. Like you said, like sometimes it's very cut clear and sometimes it's not. And in my case, in my family's case, the genetics component is not, it's not cookie cutter clear. So I'm always, when I have a really large extended family, my mom was the oldest of 8. So I'm always trying to encourage my cousins, even the ones who don't have high cholesterol, like the importance of getting tested. It's good to just know. Okay.
Yeah. And can I ask, did your son then start statins at age 4?
He did,
Yep.
yes. So, and he's done really well. And I think like most parents, my husband and I shared a lot of concerns, went through all the emotional roller coaster, not only with my own diagnosis and health journey, but now of our kids. So, you know, if anyone's navigating that, you are not alone. And I, you know, will give some reassurance that my family is doing really well and I'm doing really well. And my son has had no side effects thus far from his medications. So, and all of the lipid specialists I talk to kind of emphasize similarly to you, Anne, that side effects are very, very rare, and you pretty much know right away if it's going to be an issue.
Mhm.
So,
Yeah. Well, thank you for sharing that. I'm glad they're doing well. And I'm so thankful they got diagnosed early.
yes, yes, me too.